Okay, welcome to this live case session featuring CTO. So we're very fortunate. We've got two great live cases, one from Toyohashi, home of CTO in Japan, and Dr. Habara will be the operator there. And then one from Severance Hospital here in Korea, and Byeong-Keuk Kim will be the first operator there. We're very lucky also to have a distinguished panel. I'm Scott Harding from Wellington Hospital in New Zealand. My co-moderator is Dr. Lee from here in Korea, and he'll be helping coordinate with the live cases. And we've got a very expert panel in the CTO field. So we have Dr. Ashida, Dr. Han, Dr. Kanno, Dr. Karmpaliotis, Dr. Liu, Dr. Okutsu, Dr. Otsuji, Dr. Park, Dr. Tsuji, and Dr. Werner, all very experienced CTO operators, and I'm sure they'll provide some very valuable insights. So are we ready to go to the live cases?
Okay. Can you hear? Can you hear
we
me?
can hear you.
Thank you so much. My name is Maoto Habara. This is Toyohashi Health Center in Japan. At first, it is a great honor and a privilege to participate in this esteemed conference as an operator for this live demonstration. And we have not so enough time. That's why so we should begin the case presentation. Can you see the slide?
Yes, we can.
This case is second attempt case. Last time the case was admitted to the other hospital about the last year, August, and so she was fixed at the time, and after that LAD was performed for the PCI but failed. That's why so the case was attempted to our hospital. And next, the age is 74 male, and so that is a risk factor. And the next, and so cardiac CT shows completely occluded as ostium of the LAD, and the occlusion length is the cardiac CT is 11 millimeter. That is very short, but I don't know that is correct or not. And that is a medication. And the next. This is an angiography of the last year. You can see the total occluded as so just proximal of the LAD. And the diagonal branch is also severe stenosis, and that was fixed. And the next. And this is a caudal view, and that is a completely olified occlusion. And the next. And that is a collateral from the RCA. Of course, there is some collateral visible one. But so the case is very bending all of the collateral. Next. And this is IVAS of the last time at the other hospital. Again, this is a diagonal branch. And this diagonal branch is very large, and that is a LAD. And then next, of course, so other hospital punctured, but the lumen catheter and balloon screening technique was performed, and they used confine the ST, but puncture was failed. Next. And of course, all of the collateral was they tried, but the bending portion are there at the proximal site of the collateral. That's why those were failed. And today's our second session of the case. And so I will show today's first shot. Can you change? Okay. This is today's error shot. You can see
Keep on playing. explain them?
That is not so almost changed. Similar findings. So there are some collateral, but also severe bending there, and LAD is completely occluded. And so, could I talk about my procedure so far? What discussion?
We may have just a brief discussion. I know we're just from time-wise, but so maybe, Gerald, do you want to start out and just describe your strategy?
Well, it's certainly a challenging case because the previous operator already did what usually we would have done, tried antegrade, IVUS-guided puncture, and tried retrograde. So actually these are the two options that you have, and you just want to do it better, obviously. And you will have thought about it. Using a Confianza ST is already a very aggressive wire for puncturing. So why did it fail? Maybe use a dual lumen catheter. In addition, plus IVUS, which is possible, of course, with the Terumo IVUS, and go early retrograde. That's the only, I think, options that we see here.
Okay. So, Dimitri, this is a common problem when you're trying to puncture the proximal cap, right? And particularly where you have a very big proximal vessel, because it allows a lot of movement of your microcatheter. So have you got any strategies in mind that you might try differently to try and solve this? Because one of the problems is that, you know, the diagonals there, so direct retrograde crossing has its hazards.
A couple of things. First of all, I may have missed it, but I didn't really get a good sense of the cap at the previous IVUS. I don't know if I missed it, if it was obvious to you, but to me it was not clearly marked, so to speak. So another run with the IVUS and try to be very careful and see where the actual cap is might be an option. I think to stabilize wires, you can put a body wire down, you can use a dual lumen catheter, and sometimes even to get a guide extension so that you have a little bit more stability when you're trying to puncture. Angulated microcatheters also may work, like the Supercross or the Ventures, which at least in the US are not produced anymore, but some of us still have some stock available. But I think the first thing here would be to do a very careful, I would like to see a better IVUS pullback to try and see where the cap is. We have published this with Akiko, that when it comes to ostial LADs, it's very difficult, it's more difficult to identify the vessel with the IVUS. And there are a couple of reasons. One is that usually it goes into almost orthogonal angles, so you don't get to see the vessel as it's coming back from distal to proximal. And there's an area of severe calcification often. So for those two reasons, the identification by IVUS of that area of a proximal cap can be challenges, which I think is the case here.
Okay, thank you.
Okay, so I'm going to comment. So in terms of entry point of CTO, so from the previous IVUS, there's no obvious view. Maybe the calcification here. So today I checked the IVUS again, yes. And if there is a severe calcification, one option is IVL first. IVL in entry point of dilation is one option, because previously concussive flow is very difficult to puncture. However, today's angiography from spider view, there's a small span is here. So if calcification occupied to the heart, more heart wire, it's one option is to puncture the entry point. It means a conquest pro 12 ram or ST, my opinion is.
Okay. So maybe just for time, we'll let Dr. Habara show us what he's done today and give us a bit more information, and then perhaps we can have a further discussion.
Yes, thank you so much. Of course, the case is really difficult to puncture previously. That's why if we can negotiate it retrogradely, it helps to do the puncture, or maybe the possibility of the retrograde direct crossing. That's why about 40 minutes before we started retrograde procedure, And but next. You can see some collateral. Almost all of that was bending. And of course, at first we tried to distal one, most distal one, but the guide wire not easily to pass that bending portion. And then we tried some of that. Next, next. So this is another one. This also, our coda is looks good, but LRO, you can see some bending portion at the proximal site. And we try to negotiate the 003. We can overcome the 2-1, but that cannot stretch it. That's why it failed. And we try someone. This is another one. And so this is also distal one. But the microcacheter cannot pass. And this is, we did, most looks straight one, but you can see some bending at that. That's why, so we start with the procedure of the lateral grid. And now, just now, we perform the IBUS at the diagonal branch. Oh, IBUS.
So, Dr. Habara, did you find the ostium of the LED?
Ostium of the LED? Yes, I will show you the IBUS. This is a diagonal branch. これ1回目 ?2 回目か。And this is a high lateral branch that of the 7 o'clock and the 2 o'clock. You can see the
That's LED.
Yeah, that's LED, 2 o'clock.
And it's a what, 4-0 vessel there?
Yeah, that is not so completely occluded by the calcium.
The IBUS clearly shows why there was difficulty, very large proximal vessel and
Yeah, that's right.
calcified proximal cap. Makes it a very difficult combination.
Yes, that's, as we said, Scott, that's notoriously difficult that's a very difficult situation to market with IBUS, just because of the angulation of the calcium and the size.
So now that we've seen this information, maybe I'll ask Dr. Otsuji, who's right next to me, about how would you proceed from here, because this is obviously very difficult.
Yes, I think because of the proximal part is a very large vessel, so I think that entering the ostium is very difficult because of the wire control is not performed by the in this situation. So maybe we should use a very hard wire and also the balloon screen. But last time, these procedures all failed. So Dr. Ashida mentioned, I'm not sure the IVL is effective or not. Anyway, we enter the wire into the LED.
Just wondering,
Otsuji, in case photo strong backup support to one single wire and the IBUS and DLC catheter simultaneous, how about?
Yeah, but last time maybe operator did that, but couldn't enter the LED.
I just wonder, does anyone use Dr. Igarashi uses the balloon blocking technique, where he blocks the diagonal with the balloon to try and promote the puncture. Does anyone on the panel use that technique?
It's been described and people say they use it. I haven't had very good success with it, I have to tell you. It's easier to say than do it because it's three-dimensional. You put a bend on the wire, so there are a lot of things are moving in there. So it makes sense to put it on a PowerPoint, but when it can get to do it, it's...
You have the pre-shaped curved microcatheter.
Yes.
Yeah. Is it
So
user effective?
So the supercross, the problem is when you take a very stiff wire, it tends to straighten.
Yeah.
That's the problem. Whereas the venture catheter was very good because it would maintain its shape. The problem is the venture catheter is no longer available.
For a good price, I can give you a few.
But the problem with the supercross is that even the 120, as soon as you put a very stiff wire in, it becomes straight.
And you need to have a notch, and there doesn't seem to be a notch here. I was wondering, you mentioned the CT scan that was done. What did the CT scan tell you about the calcium distribution?
Maybe it is difficult to show you now. That is so cardiac CT shows some calcification of the LED ostium, but that is not completely occupied the vessel. I think that is the opposite side of the vessel of the diagonal branch. And that's why we can penetrate to which direction more a little bit safe, because that is maybe protect to go far.
So in the earlier attempt, the Confianza ST was used. We don't have experience in Europe, at least, with the ST. But I have the feeling sometimes that in a Gaia 3 or 4 bend is more penetrative than a Confianza. What will you try?
Yes, according to your suggestion, that I agree with you. Gaia ST, that is also other hospital operators. That's why I don't know why they selected the Gaia Confianza ST. But of course, this situation is after the penetrate to this puncture, Gaia is more better. That's why. So at first, I touch it to the Gaia, but that is not good movement. That's why now I was guided, and so now do W lumen Sasuke, and this is a Confianza, and you can see 2 o'clock the entry of the LED.
Not so calcified.
Yeah, that light. Ostium is not so calcified, but a little bit proximal is some calcification are there.
So, do you think you need a stiff wire like Confianza?
Yeah, but
Dr. Werner said Gaia is more effective.
Yeah, I said I used Gaia second at first, but Gaia second cannot go into the such a hole that go to the little bit distal direction. That's why I changed it this time.
Dr. Habara?
Yeah.
I'm just wondering which IVUS-guided wiring technique do you take? I mean, do you want to do the tip dissection technique or just conventional IVUS-guided wiring? Which technique do you take?
Yeah, as usual, a conventional one. Because almost guide wire is opposite side of the IVUS. And of course, I asked the second operator to check the guide wire direction to check.
It seems to me that you have to point it towards the left, right? Your wire angiographically. Right?
ちゃうねん。奥入れんとセカンドワイヤーがあかんねん。And so in Japan, we have no, なんだっけ、already figured microcatheter. I forget the name.
Supercross?
Yes, that's right. Supercross. Thank you so much. That's why. So maybe it is sometimes.
That's better.
Yeah. The direction is good, but this is not good point. これ Direction is good. いいよね。
Yeah, for the first time, your direction is good.
Yeah, thank you.
Especially on the IVUS.
Yes,
Looks
and
very
you can
good.
see it with the code registration also. Right? That's a spider, right? So it has to be that way, to the left, up the LED, correct? And the IVUS, yes, Gerald. It
So it
seems you
looks
have
like you've-
penetrated a little bit.
Yeah.
Are you using any microcaster to support the wire?
Dual lumen.
Yeah, this is a dual lumen catheter. Yes. Okay. Yeah, one more distal guide wire can penetrate to the distal. I want to advance the double lumen catheter a little bit.
Yeah, it will give you more support if you can just,
Of
without,
course,
without losing what you've got.
Yeah.
One of the difficulties here is that you've
Yeah.
had to make a big curve, right, to make the puncture. And then if you continue with that big curve, it's very easy to become subintimal. And so this is one of the, I guess it'd be interesting to see what the panel does at this point, because
Yeah.
you can't just exchange your wire with the double lumen catheter. So often, actually, I then will take this wire out or try and exchange it for a Corsair. At this point, if it falls out, there's a hole there, and often you can find that hole again. But the problem with trying to continue with this wire with a big bend on, it makes it very, very difficult to do accurate wiring.
Scott, in all honesty, I'm worried more about exiting with this bench rather than getting a little bit subintimal. I mean, if you can control your subintimal course and then do a re-entry in a good way, that wouldn't be the end of the world.
So I guess who would swap the wire? Would you continue with this bend at this point? Their comments?
First, I would keep the position that I gained and try to get a little bit ahead.
Yes.
To get some more support. And anyway, the bend, the tip during working gets straightened. So maybe you get by trying to, now this direction, of course, is not favorable. That looks better. Try to kind of work out the bend. Straighten the vessel, the guide wire during your manipulation a little bit.
Yes. So entry was.
The other thing you can do is you don't really need the IVUS real time now. So if you can just give yourself a little bit more space to work with, you know that you're in the right spot. So continue real-time IVUS here. I'm not sure it adds much. So maybe just by getting the IVUS back, it will help you manipulate the wire a little bit better, as Gerald said.
How do you think about the double lumen catheter or change the single lumen catheter? Because
I would probably change to single lumen, and then it allows you to alter your shape. Just one question, Habara. Are you working in biplane? Because we're only seeing one view.
Yeah, this is our biplane view.
Right, okay. So I presumed you're working in biplane and that we were just, because it's very important to swap between the views to make sure that you're on course in both views.
I mean, I think that if you trap the exchange, maybe you will not lose your wire. And then if you take a low-profile microcaster, you might actually be able to wedge it in the proximal cap. It's not easy, but again, with trap...
it is not easy, Anyway, I will try.
So the another option is to gain the much support, change the guide catheter, I think. Jadokins, short chip Jadokins left 4, maybe to more coaxial support, I think.
Yep. At first, so we thought that, but this is not LED just Austrian. This is a little bit distal. That's why I think that guiding catheter of JL is not work because
so large LMT and slight length of the LED.
Yeah, length.
Okay,
that's right.
I agree.
I think the side door exit from the dual lumen catheter is somewhat distant from the proximal cap, so it's not good to get full support from dual capacitor. You may advance further to get full support.
So I guess we need to understand what the issue is. So is the issue a lack of support? But it seems to me more of an issue of direction of the wire at the moment and not being able to control the direction. And so I think the only way of solving that is to put a microcatheter in and change the wire.
穴開けたからな。ガイア用意してる。
But because, do you want to comment, Dr.
Yeah.
Habara? Is the problem that you cannot push the wire, or the problem is that you cannot steer the wire?
Yeah.
Yes, I think that the problem is controllability of this confines Pro guide wire. So entry point is not so hard because this confines can cross, but controllability is the worst. And so I would like to change to Gaia X4, and we can advance the Gaia X4, turning the 180 degree and advance more, I think.
Okay. Thank you, Dr. Tsuji sensei. I agree with you, and so now I change the microcatheter, and after that, if possible, guide wire will be changed to the Gaia X4.
Could you show the audio cranial view? Is it enough to the guide wire support in this position to change the microcatheter?
I think no.
Because sometimes the wire prolapsed.
Yep.
Yeah.
Like that. Can you see?
No.
Yes.
Yes. We can see.
もうちょっと。
Yeah, you have a mile of wire. You're not going to lose it.
ちょっとワイヤー触らんといて。来たら言って。
How about the balloon screening at this time to prevent microcatheter prolapse?
I'm not so much experienced for that. Is it work?
Yeah, because sometimes when we
Penetrate
gain
to
the severe bending curve like a reverse wire, we sometimes difficulty. We have sometimes difficulty to microcatheter insertion. At that time, we sometimes block the balloon screening the distal end, not to prolapse the tip end.
Yes.
You already pull out the IVUS, right?
Yes, already. Anyway, from now, Corsair XS will Corsair advance to the CTO entry.ちょっとこれ水。入るかな。Okay. Yes. いいよ。Now coming.
Very nice.
Yes.
Okay.
入った？入ってへん？
Okay, maybe get in.
入ったよね。
Yeah.
まだ？いやちょっと待ってこれちょっと入れたいな。
I think the microcatheter already crossed to the region.
Would you change to a Gaia now, any of you?
Definitely Gaia, because it's a much more controllable wire than
Gaia,
Conquest and much more directable. The CT scan suggested that the occlusion length was only 11 millimeters. So if we can see the distal cap clearly, we should be able to, wire it 3D by angiographic guidance.
Well,
Did you change the wire, or are you using the same wire?
Yes, I will change. But I'm wondering about that. So Corseo cannot reach to the entry. How do you think about that? Already touch it?
I think you're good.
I think it's an entry.
I think it's in
Okay.
the entry.
I will change.
We will find out.
Yeah. It's not us losing the wire, it's you. So
you have a reference
We
in
can
this
say-
projection of the distal cap or in your lab?
No,
Because we-
this cap is already calculated by the X-flux edu, and the perpendicular view was calculated so that epicranial in the airway caudal is best for the distal target.
Dr. Habara, we
Yeah.
only have 1 minute left.
Yes.
Sorry, but it's been very interesting. Can you just maybe summarize your strategy from here?
I'm sorry, so we cannot get enough time and reach it to the distal end. But today, this is entry point is very important. That's why at first, we started a little greatly but failed. And so this is the IBUS guided puncture with confianza in the double lumen catheter. And from now on, we try to negotiate the guide wire to ダメだ. This start with a Gaia next floor because so we could penetrate with the confianza. That's why so we hope I have a hole in the LED ostium region.
Okay. Thank you.
Thank you so much.
Now, let's move to Severance Hospital. Hi, Dr. Kim. Can you hear me?
Yeah, I can hear you. Can you hear me?
Yes. My name is Rehiri. Welcome to CTO session. Can you summarize today's case?
Okay, so good afternoon, everyone. So it's great honor to perform the live demonstration, especially this year, third year TCTAP, and also the thanks to the Scott and the moderator, Professor Lee. So let me introduce our team. So the Professor Yongjun Lee, and also my fellow is Chunchang Jung. So today we had a case of the RCA CTO. So the Yongjun Lee, could you show us today's case?
Yes, sir. Next slide, please. So our patient is 51-year-old male who came to our hospital due to stable angina. He had been diagnosed to vessel disease with double CTO at LAD RCA 1 month ago. We have successfully performed PCI at LAD CTO. We'll show you the images later. Next slide, please. So this is the initial angiography. As you can see the RCA CTO lesion, and we could also see the collaterals going from the distal RCA to LAD. This is the left coronary artery. As we have suspected, we could also see another CTO starting from the proximal LAD. Next slide, please. So at 1 month ago, we have decided to initially perform PCI for the LAD CTO lesion. The wire was successful with the XDR. Next slide, please. And we have successfully implanted the 3.5 38 millimeter DES. And you may be suspicious about the distal lesion. We have seen the IBUS, and all of those lesions were negative remodeling. Next slide, please. So the RCA CTO is today's target. Next slide, please. So we have done the CT analysis. The CTO length was suspected to be about approximately 14.5 millimeter. Next slide, please. There was not many calcium, but only at the proxima there was a minimal calcium, and this star was okay. Next slide, please. And this is the matched image with the NPR. Next slide.
Okay, so this is the today's CTO case. Is a double CTO. So 1 month ago, LAD CTO was fixed successfully, and also today the target is RCA CTO. So could you show again the today's previous angiogram of RCA CTO?
RCA, first line.
Yeah.
This.
Okay.
How long did you wait from the first CTO to this one?
4 weeks. 4 weeks.
4 weeks. 1 month.
1 month.
1
okay.
month.
Yep. Yeah.
Okay, so we might
So
just...
actually, yes, go. Okay.
We might just have a brief discussion about strategy. So maybe we can
Okay.
start with Dr. Park. Can you just describe your approach?
My first approach is there are some the microchannel at the proximal LAD, so integrate approach is my first. And the second is the LAD flow and the collateral channel check, and second is retrograde.
Okay, Dr. Ashida?
Almost the same opinion. So I check the chip induction from antegrade. Maybe there is a microchannel. I believe.
I think I agree. Certainly a tip injection would be very important here. I think most people on the panel are nodding their head. So most people are saying, as you would expect, antegrade, a tip injection. There's a suspicion of a microchannel, and then obviously there are a number of options if the antegrade fails. So do you want to show us what you've done so far today?
Okay. So actually, everybody can know the most problem of this kind of CTO is a kind of a bridging collateral versus micro antegrade flow. So sometimes it's not easy to discriminate, and also the very looks easy case, right? However, we so experienced many times this kind of bridging collaterals not easy to get the distal stump. So anyways, the most one problem is I will show you today's case later. So the some side branch is approaching near the CTO segment, and then the second segment, Professor Park also mentioned, if we fail the antegrade approach, we use the retrograde approach. However, previous LAD CTO is there was really no promising septal collateral. So today we had some CTO workshop with Scott. So in that session is also some importance of the IVUS evaluation of the poor distal bed. Anyways, I also want to know some collateral flows developed or not. So and maybe 1 month is not too long to have some improved collateral flow. However, anyway, block the flow and then reopen, so everybody can see today's angiogram. 오늘 angiogram 보여주십시오. We had a bilateral femoral approach, and this is the today angiogram. So some flow we can see from the LAD flow. However, definitely some antegrade flow we can see. However, just some very tight portions, so we are not sure there is fully connected or not. And also definitely LAD distal was a distal vessel expansion also occurred, and with minimal some collateral flow. Next one. This is the collateral flow. So some distal after finishing the stent line, and then the next septal channel, we can see some epicardial channel. Next. So this is the LAD. Anyway, also I want to see these findings is very tiny mid to distal LAD. However, is today's angiogram within just 1 month later. However, the vessel expansion is definitely occurred. And next one. And then we check this angiogram. So maybe I also we can see some antegrade flow. Next one. Yeah. After to perform the tip injection. Next one. So, next one. Yeah. Next one. Okay. A little bit removed. However, we can see the some flow. So the previous doctor told me this kind of tip injection very important. However, some proximal distal margin is too long, so I do not want to hamper of some CTO segment. So a little bit removed and then check the antegrade tip injection. Definitely, I can see some flow. And minus. 처음에 찍은 거 한번 보여줄까요? So initially, I told you 한번 그 아까 사이드 브랜치 나가는 거 스탑 해주실래요? Please make the stop imaging. So from the RCA angiogram, RCA 찍은 거. Stop. Okay, so, stop, yeah. So after branching out of the conus branch, and then some antegrade flow we can see. However, another linear flow going upside, there is also would be some problem to do the antegrade approach.
Okay,
so anyway, I want to perform the antegrade approach first.
Okay, so maybe we'll just talk to the panel just for a second.
Okay.
That I think everyone agrees with an antegrade approach. And I think we've seen the tip injection, and there's always this debate about whether this is a visible channel within the lumen or within the vessel, or whether these are bridging collaterals. So maybe we can have a discussion about that, and maybe we can have a discussion about what wire people would start with. So Gerald, what do you think?
If you look at the aerial view, there is some doubt that there is a continuity. It looks certainly on the LEO view that there is a subtotal occlusion, that there is some flow, but as BK pointed out, I think he doubts that there is really a continuity and that is overlaying bridge. But anyway, it's a short occlusion, so the usual escalation starts with an XT type wire, whatever you take, and then to the Gaia with a contralateral injection, avoiding any further antegrade injection, I think. For the retrograde options, they would be challenging, but I don't think we need retrograde in this case.
Okay.
Dr. Kim, I am Okutsu.
Yeah, hi.
Hi. This is a very great case. I think that this occluded segment have not so calcified, and the entry have a tapered. So I asked you the indication of the HDR technique for this case. How do you think?
HDR meaning the high media injection?
Yes. HDR.
Okay, so but well, that is also very good option. However, we are for discussing anyway, we can see some antegrade flow, and also Dr. Werner mentioned that kind of some flow is within the vessel or not. However, the patient's vessel size is not so small, meaning we can control some antegrade wiring. So I just want to start with the antegrade wiring first, with escalating the weight.
Okay. I might just ask Dimitri, who's sitting here. Obviously, everyone would start with antegrade wiring, but if there's ever a vessel made for ADR, this would be it.
Yes. So
would you do that before you went to retrograde?
I think that all options, all cards are on deck here. What I would do probably before starting is, I think the reason you don't see good septal collaterals from the LADs because you have this humongous ipsilateral collateral there and essentially almost TME3 flow past the distal cap. It would may be worth putting a balloon in the proximal RCA, keep it up for about, 5 minutes, and then take a contralateral, and sometimes you'll be surprised how many septals will light up, and at least you know that you have another option on deck. I don't think there's anything wrong with what Gerald said, start with a tapered wire and go with some soft Gaia, but then in this case I would have, in the absence of retrogrades, I would have zero threshold, just throwing a knuckle and doing an ADR. If this is not an ADR case, I don't know what is.
Okay, so Dr. Kim, do you want to show us what you've done?
Okay, so our broadcasting time is very short, and also SJ Bach and DW Bach, as they don't like not finishing the case within the designated time. So I had some stress on nerves of the finishing the only 30 minutes. So I started earlier, and then based on two catheter. Next one. Anyway, I had some time, so I checked some retrograde approach would be possible or not. So for the anchoring, I put the soft wire in the corners branchy, and also really touching the tapered CTO proximal portion with the Corsair Pro XS. Negative, positive. Yeah, so this is the from the aerial cranial view. So you can see the some collateral flow, the septal, positive. And then we had a big one. Okay, so this is the tip injection. However, you can see this is the not true septal collateral. So it's a very long tortuous epicardial flow, alveolar branch to distal flow. So meaning and not easy to use this route. Anyway, based on this situation, I started antegrade wire escalation started. Next one. So, however, minus. So we keep this catheter. So because everybody experienced sometimes in case of the ipsilateral antegrade flow from the breaching collateral. After some breaching collaterals damaged, and it's not easy to check the distal portion is a true lumen or not. So in that case, so I want to use this catheter tip injection. Sometimes could tell us the distal wire tip portion without antegrade injection. So anyway, next. So I started the antegrade wiring. So with the XTR first. Next one. So initially, so frankly speaking, so that wire very easily crossed the region. However, as I previously told you, maybe you can see some distal portion going up side branch. That is the most big problem. Next one. So I tried many times. Try. Next one. Minus. Yes, you can see this wire portions is just going upper side, so not the direction of the CTO distal portion. So in this step, so I want to change the antegrade wiring into the parallel wire system. So kind of not parallel, so I want to make some mark wire with a very big side branch is approaching adjacent to the proximal CTO segment. So the previous wire is go into the side branch. This is the wire is shown black, and then the main branch wire is XTR, and a little bit advanced. So, but the wire position was not so good. Positive. Anyway, the wire go cross, but some plane was not matched. Next one. So from the aerial view, the position would be good. However, the aerial view is the plane is a little bit far from the expected success, expected CTO path line, true path line. So this is the work of the wire. So as I already two wires in the this segment. So and also we can use again. So use again the double lumen catheter. However, the next one. So from this image, that wire is a different portion. However, the start of the wire in the branching the two side branch and then the CTO segment is the initial point was not so bad. So I just remove and then try to wire properly anti-grade movement I tried. So until now, so what do you think the anti-grade approach?
So maybe Dr. Tsuji, do you want to comment about where you would go from here?
BK, this is Otsuji.
Yeah. Okay.
You decide the entry already? CTO entry. Very close to the second wire. Or very close to the first wire. So, for me, I would like to use a double lumen catheter and leave the second wire there. And then use a more stiffer wire like Gaia next one. And try to puncture, try to move the wire to the more downside.
Right.
And also, in this situation, I usually use aerial cranial view. Because just aerial view, only we cannot see the wire longitudinally. So anyway, you have enough chance to penetrate undergrad.
Okay. Okay. So actually, I am the student of the teacher Otsuji sensei. So I had a similar concept. So I thought this is a time to change the anti-grade wirely. So some image was missed. So using the double lumen catheters, and then I changed the wire into the Gaia next one. But this wire is a little bit removed. So we cannot use this wire as a second portion. Next one.
I might just ask the panel. I mean, my practice has changed recently. Gaia next one, I really just do not use. And in fact, when we have a very clear target like this in a short distance, I understand it's around a bend, but the bend is not extreme. I now tend to use a stiffer wire because it is more directional, more easily to penetrate the distal cap. So I think, one thing about 3D wiring, what it's taught me is actually using a higher penetration force wire actually leads to more success than, a low penetration force wire. But I'd be interested to know what people would do. Would people generally use a Gaia next to one in this, or would someone use a more penetrative wire? I'd certainly at least start with a Gaia next two. But
yeah, I think it depends on the region characteristics. And this is short region, and this target is also tapered. So, I mean, we don't need a higher penetration force wire, I think. Only I also choose a Gaia next one to this kind of regions, I think.
Well, the issue here is that we know he's engaged all the bridging collaterals that there are, so he has a pretty good understanding of where not to go. So he can just get a little bit more penetrating wire, come back a little bit scratch inferiorly, and just get to the vessel.
So, Dimitrios, let me ask you, would you use a Gladius for this sort of?
I'm not dogmatic. I think a Gladius would be fine. I think a Gaia would be fine, as long as you are on the right trajectory and stay away from the bridging collaterals that he was in. At some point, he had 2 wires and bridging collaterals. Now it seems like there's a little bit better trajectory, and it's going. I don't know why he's stopping, but.
It's Fluorostore. He's already through.
Okay. All right. Okay.
Am I right?
Yeah, right.
Yeah.
So this is
That looked good.
so as everybody can see, this is the wire of the Gaia next one. So the reason why I choose the next one is weight is also important. However, some bridging, some bifurcation side from the CTO and side branches is all kind of some polymer jacket wires, including the Ocean Black or XT series. So slipped into the only go through the side branches. So and also anyway some power needed to very short tiny total cost. So the reason why I choose the Gaia next one, so you can see in this portion is wires very go into the within the CTO path. Next one. So and then the really touching the distal tip of the array of view and then the array of caudal view. Next. Next. Yeah. So and then so the sometimes I also the wire change. However, the this vessel size too not so small. So I just go with the next series. However, it's better to change it a little bit lower weight wire would be better. Next one. And then we check the distal flow from the tip injection of the previously we selected the septal collateral, and also we can see the wire location is good. And then the wire move again, and within the anchoring, and then simultaneously advance the Corsair Pro XS not difficultly. Yeah. Next one. Next one. And we check again anti-grade flow. Next one. Next one. Yeah. And we change it soft wire very easily. Next one. And then and this is the we perform the IBUS examination. Can I show the IBUS image?
Yes, just quickly. We have about 4 minutes before we need to go to the lecture.
Okay. After ballooning, yes, we perform the IBUS. Could you show the Professor Jung-Kyu?
Yeah, this is the initial IBUS. The distal vessel was about 4.0, and starting from the distal and to the tip of the catheter, the lesion length was about 38 millimeter. As you can see, all of the wires were in the true room. And there are massive clock on starting from the 6 to 9 o'clock, I think.
Is that true?
So we're gonna.
What are your else
Okay, so the time limitation. So from the all wire is.
It looked like there was a subintimal area there, which is interesting.
Proximal portion.
Yeah.
Yes.
Oh, yeah, right. But some portion, but we can see some side branch approaching. So
Maybe if you can quickly run us through that again. I think this is very instructive. No, the IVUS, if possible. Can we just see the IVUS
So
again?
from the size measuring, so I want to put the 3.5, 38 giants TS. So if the distal lesion is some remained, however, anyway, I put the one stent, and then I will exam again, and also we will decide one more stenting or sometimes DCB of the distal portion. So I will decide. But I think maybe just one stent would be enough.
How many frames are you working on?
7.5.
Okay.
This is the new machine. So testing. 스페셜. 엔지어 프리. 얼른 코너 스페셜. 얼른 코너 완성.
It can be one of the difficulties with IVUS that length is not always as accurate as you would like. Look like the stent may be slightly short, but you know, sometimes the IVUS says 30 millimeters, and you take 30 millimeters, and it's 32 or 33. So I think whenever I have IVUS, I try and bear that in mind and try and not, land the stent to the millimeter.
16, 14, 16.
I think the full back system comes through a short curve.
Yes.
So maybe we underestimate set length.
So Dr. Kim, I think we have to go to a lecture now.
Okay, so I will show you the final. Anyway, the image of my final shot of just after stenting. Okay, this is NGO. So I will perform the IVUS exam, and then the NC ballooning will start it.
Thank you very much for your demonstration.
Thank you.
Now we have one lecture, featured lecture time, real-world application of penetration plane method in CTO PCI. Dr. Kenyanas, please.
Thank you very much, Anahili. So,
Very short.
So this is the concept of penetration plane method. If the guide wire can be positioned along the vessel axis at the end of the CTO and maintained on that line while advancing, it will eventually advance the vessel beyond the CTO. So this is the rationale of the penetration plane method wiring. So anyway, when we started the penetration plane method, we need to the perpendicular views. So we called these two views as OPV and PPV. So if the shaft and the chip of the guide wire are placed on the vascular axis of the distal to lumen as the PPV and advanced, the wire will reach the distal to lumen. The distance from the guide wire chip to the distal to lumen can be checked as the OPV like this. The OPV and the PPV are the two orthogonal planes. This is a fundamental important point. And the OPV and the PPV can be utilized interchangeably depend on the clinical situation. So in the past, we developed the penetration plane method to use the plasma-mediated ablation system because plasma wire has a little much power, and it can be make a bigger space after ablation. So if the plasma wire ablated the vessel wall, that means it can make it a bigger space at the vessel wall to make it a perforation. So for the safety, we for control the plasma wire appropriately, we developed the penetration plane method. So I want to say that the importance of the perpendicular views to understand the position of our guide wires. So this is the example is the middle of the right coronary CTO like the BK case. So when we see the LO50, so you can see the wire chip inside the distal to lumen. So when we rotate the C-arm, it's only the 45 degrees. So still, the chip of the guide wire in the true lumen. But so we checked the additional 45 degree views. That means in the perpendicular views, from the original view. So you can see the guide wire chip is outside the distal lumen. So accurate information can be obtained by evaluating the target vessel from the two orthogonal direction is very, very important to perform the penetration plane method. So, when we treated the mid-RC CTO, like a Vicky case, it's very easy to understand the perpendicular views. So usually the operator uses RL50 and RL40 or RL30 or the RL caudal, 3030 RL caudal you used to identify the wire position. So because it's around in the middle of the RCA, so vessel axis runs parallel to head-hood axis of the patient. That's why very easy to set the perpendicular view like this. So however, so how about the orifice of the right coronary artery CDO or the distal bifurcation CDO? Can you imagine the real perpendicular views for setting? So it's very difficult. So the vessel axis are mostly inclined in the three-dimensionally to head-foot axis of the patient in clinical setting, so that it's very difficult to calculate the perpendicular view under such circumstances. So now this is the first version of the software to calculate the perpendicular views. So, but this is the first version. So in the first version is a one-on-one calculation. So the calculation result was often unrealistic angiographic projection. For this case is a LO52, the cranial 38, but the perpendicular view is LO67, the cranial 32. This is outside of the range of the C-arm, so that's why it was not useful for the daily practice. So we changed the concept. We started to calculate the vessel axis of the target segment. The view angles in the two orthogonal directions can be analyzed according to the vessel axis. The angles in the two orthogonal directions from the three-dimensional orbital diagram is visually analyzed. And also, when we set the perpendicular view, to do the PPV and the view one is a real perpendicular view. So it's ideally we want to set these two views. But as you know, the C-arm movement is a little bit limited. So we can use the view 2 and the view 3 because these two views located in the same plane of the view 1 on the green plane. So when we use the PPV and view 2 and PPV and view 3, also these two angles is the real perpendicular views. Of course, is this kind of oblique view. Sometimes we can see the shortening the target region. So I showed the one case. This is a right coronary CT with the second attempt. You can see that some region is the donor artery. LED is already stented. Anyway, so first attempt the integrated approach tried, but wire is going into the subintimal space. And finally, is the operator tried to HDR, but anyway, it's in the first attempt the procedure has been failed. So this is the second attempt. The initial shot is LED is fine. You can see some good collateral to the PD and RV branch here. So of course you can see the very big hematoma, and also we can see the small channel to the branch like this. So anyway, in the second attempt, I started with the red approach, but I failed selected the septal channel to the PD, but the channel is nicely connected to the RV branch. So I selected, so this one. So anyway, after crossing the channel, I checked the chip injection from the RV branch. So we can see the distal rounding zone here. Okay, so that is the aerial view. So now we calculated the vessel axis of the distal landing zone here. So when we make it a two line like this, so software is calculated the vessel axis automatically, and then we can set the two perpendicular views. So in this case, I use the LAO 61 caudal 3, and the other one is the RAO caudal view. Beta is 38. Beta mean is oblique view. So oblique angle is 38. So, but these two views on the real perpendicular plane of the vessel axis. So anyway, we can set the angle like this. So we start, okay. So we studied lead-red wiring, but according to the instability of the lead-red system, the lead-red function is very difficult. So I started the undergrad approach. After selection of the side branch, I dilated the region is here and checked IVAS and IVAS guided proximal cavity puncture, so like the Maoto's case. So anyway, this undergrad wire is come to almost distal of the true lumen like this. Here is a wire, undergrad wire is almost overlapped with the distal undergrad wires. So we checked the angio chip injection. So the chip direction is a little bit left side, but the shaft is almost overlapped the distal true lumen like this. So we set this view of the penetration plane view. So and also that we check the another perpendicular views. So we can check the direction of the wire to the distal landing zone. So you can see the direction of this wire is very nice. So it's time to puncture by this antegrade wires. So I use the Gaia Expo. So we put the retrograde wire to the distal true lumen as a landmark. So in the PPV, you can see the wire is almost overlapped with the retrograde wire. And also, you can see the antegrade wire almost touched to the retrograde wire. That means it's at a higher chance to get the distal true lumen. So it's time to check the chip injection. So PPV and OPV, you can see the wire is in the true lumen, so that we can get the distal landing zone. So this is the final result. So. And also now we are developing the SPLAX Edu, the analyzing calculation software, the for CT. So this is a LED, light CTO, and you can see the very nice landing zone because of the direct communication from the LED. In this kind of the case, so only install the actual data is the software automatically calculated the volume rendering images like this. And here is a PD and the PL branches bifurcation you can see. So the software, we can magnify the image like this. And then when we drew the line, so software is calculated the vessel axis automatically, and we can see the orbit curve and set the PPV and OPV. Okay. So in summary, the perpendicular view settings are most fundamental element of the CTA wiring in the penetration plane method. Yeah, using the SPLAX Edu, perpendicular views can be set up very easily with two angiographic images. In near future, PPV and OPV can be analyzed by the CT image before the procedure. Thank you for your attention.
Okay, I think we're at time for the session, so unfortunately no time for questions. I'll wrap up the session. First of all, I'd like to thank our operators. So Dr. Habara shows a very nice case and some strategies for overcoming a difficult proximal cap. I think this is not an uncommon problem, and understanding those strategies is important. And then Dr. Kim showed us an antegrade wiring case, and where there was issues differentiating between bridging and microchannels, but managed to overcome that with antegrade wiring. But very interestingly, on the IVUS, what we saw, despite seeming to be fairly straightforward antegrade wiring, there was a small segment of subintimal tracking, very short. But so it just shows that what we think we're doing, fluoroscopically, is not always what we're doing when we check on imaging. And then, of course, we had a very nice lecture emphasising the importance of orthogonal views for wire direction. So I'd like to thank all the panellists and my co-moderator, Dr. Lee, and wrap up the session. Thank you.